We have just a few more minutes before everyone should be back, about 3 minutes. So we have 3 minutes before everyone should be back. So meanwhile, just go ahead and you still have 3 minutes. But if you're sitting there, you can go ahead and place your name in the campus in the chat, and that way that'll be out the way. All righty, so come on camera. Let's go ahead and move forward. If you would place your name and campus in the chat again, make sure you check your screen name to make sure it matches how it appears on the roster. And as always, these sessions are recorded and can be viewed by the attendance administrators. All right, so you just took your exam. As I mentioned before the exam, the last class takes their exam on Friday. I think they finish around 4 o'clock. So we usually do the exam analysis thereafter. You will receive a message in the announcement section when the grades are actually posted. You know, we don't give out preliminary thumbs ups or downs or smiley faces or anything like that. Just go ahead and start preparing for the next exam. And remember, your HESIs, it can cover anything. So make sure each time, even though you're focused on that next unit exam, but still go back and be looking over that material. Start chunking that material up so that it's a continuous review. When you hear the word, you automatically certain things start populating in your mind. So just be repetitive with looking back at your concepts, looking back at your concepts, and this is for all of your courses. And then remember also the NCLEX too. It's a combination of all the courses together. So continuously be looking at your content. And then for those of you, which I think is everybody, at least have more than one class. Usually after this first exam, you all things kind of, I know it's the same time, but it seems like it moves a little bit faster. So just make sure that you're looking back at your schedules to see what things looking and seeing what all you're responsible for. That's work, family, school, all of that, and see what you can rearrange, delete, or even put on pause. So for those of you that are just coming in, make sure you put your name and campus back in the chat. Okay, so let's go ahead and look and see where we're at and where we're going. So this is week 3. We took the unit exam, and then we meet next week, which is week 4. We talk about communication. Well, we're actually going to do like just a brief overview of week 4 and 5 today, anyways. So, but specifically, we will dive deeper in next week on communication and start looking at all the people that help us provide that best care for our clients. So we start looking at others on the healthcare team. We do have these lessons and these adaptive quizzes that are due. And then week 5, we look again at the healthcare team, and we look more like a leadership, and then more delegation, and then you have another lesson and another adaptive quiz. Then on week 6 you have another exam. So we meet 2 more times and then another exam. Like I said, just make sure that you're going back, looking at all of your content. Just chunk it up if you can. Just little bits and pieces at a time, because you will see all of it again in some form, whether or not it's on your NCLEX or your HESI. So just making sure, that you have that strong foundational knowledge about those concepts. Remember that HESI is everything. It's just not, your leadership courses. It's not just your med surg. It's a compilation of everything. All right, so let's just go ahead and just start looking at where we're going for next week. All right. So I mentioned the interdisciplinary team, the healthcare team. So even though we're there, we're that central piece, and everybody's going to be looking for you, coming to you for the answers, what to do, and they have all these questions. But it still requires us coordinating that care for that client, whether or not it is ensuring that client is receives their discharge instructions, make sure that we reinforce those instructions and they're moving on to a different setting, whether or not it be home or another facility, whether or not we're in that facility and that client has to seek physical therapy. We may have to coordinate care where we have to bring that dietitian in because something might be going on with that client's nutritional status. But nevertheless, care coordination is recognized as a professional standard. And then it's an essential competency that we should have. Like I said, we're sitting in that middle, and it's like, well, where's the healthcare provider? Where's the speech therapist? Where's the physical therapist? They are there, but they're looking at us to help coordinate and keep up with the client and all the many things that each of our patients need. Care coordination, and just think about the words, care and then coordination. It is fundamental in improving the quality of care delivery while reducing or decreasing inappropriate use of healthcare services. So, what do we mean by that? So, we don't want to underuse healthcare services because that's a misuse of it, that's using it inappropriately. And we don't want to overuse healthcare services. Either way, it's an inappropriate use. So, let's put that into some examples here. So, underuse could be we have a patient in the long-term care facility, and that client is receiving therapy, occupational speech, either one of them, physical therapy. Then that client also they have an appointment to see a specialist. You know, I don't know, maybe we'll just say that they had hip surgery and they're having to go back out and see the ortho, but they're in your facility for rehab, or even if they're at home for rehab, but we're coordinating that home health care for them. So the client needs to be seen by both the specialist and also the therapist. So we're in the middle, and it's up to us to coordinate, plan, to in the event that we know therapy. So we're going to talk about communication too here. So we know that therapy more than likely is going to be in our facility or arrive at the patient's home morning or whatever time of day. We want to make sure that that appointment for that specialist doesn't bump heads with when that patient is supposed to be seen by their therapist. Because if they're supposed to be in two places at one time, so to speak, they can't be in two places at one time. That means that one of those services they're not going to get. We don't want it written down on the patient's record for physical therapy that the patient refuses or the patient is unavailable, because we can easily just reschedule, not even reschedule, but schedule that client's appointment on at a time of day that we know that their therapist more than likely will not be seeing that client. Or we can just have a conversation and say, hey, the ortho, they can only get this patient in on Monday at morning. Is it so that you can move on and see a different client and come back to this patient, when they return to the facility? So that's a way that's an example of inappropriate use of healthcare services. And that care coordination, you're going to have to be talking to them, knowing everything about the client, what they need, kind of foreseeing, so to speak. Care coordination organizes care and information around patients' needs and their preferences. Even going back to that client that has to see the therapist, what if that client, the therapist come and say, hey, patient in room 201, they've been refusing therapy. We go and talk to that client. Client says, hey, they come in here too early or they come in here too late. On the example, the client says that they come in here too early, we can ask the therapist, hey, can this be your last patient for today? Therefore that time is, not as early as it has been. And then on the flip side, the patient might say the therapist come in too late in the day. And sometimes it's just that communication and understanding what that client's preference is. It's not that they don't want to receive the care, but we do want to include their preferences, things that they value, because remember, it's them that's receiving the care, and we want them to be as compliant as possible. Um, and we don't want something like that. It's the reason why they're not getting the care that they need is because we didn't coordinate that they were going out to see a specialist, and that we didn't communicate that they're not a morning person or they are a morning person. So care coordination is one of the 6 priorities identified by the National Quality Strategy for providing more affordable, improved, and patient-centered care. Here it is, patient-centered care, patient preferences. Effective care coordination helps prevent fragmented service delivery, cost inefficiencies, and poor health outcomes. Because think about it, that client can't get to see their follow-up appointments for their ortho. They're having to go back there, making sure that the bone is healing well, and they're doing all those checks. If that client can't get back in to ensure that that bone is healing well or the surgery took, then that client, it might mean the difference in that client being able to walk and take care of themselves or not. It is important for everyone not just those with chronic conditions, but as all may need improved coordination at some point in their lives. So not, for sure, care coordination for those that have chronic diseases and more than one. We have the patient that's needing the therapy. They're needing to go see the specialist. Everyone needs that care coordination. So just so that they can receive all the services that they need. And that's part of providing that best care. So if any questions on care coordination, a whole bunch of moving parts. But guess what? We're right there as a nurse. We're right there in the middle, and they're coming to you. So care coordination is essential in improving quality of care and reducing healthcare costs. Because just think about that patient in room 201 that needs to see physical therapy and ortho. In the event that we get the patient to see therapy, they get back up and walking. They go to see go to their follow appointments, follow up with ortho. They know that bone is healing well. That client is less likely to need further assistance from that ortho or a redo of surgery, or it will lessen the chance of that client not being able to take care of themselves, which equals a decrease in healthcare costs. Because if that client doesn't return to their optimal level of care, then that client may need assistance around the clock, where before they did not. Hence, that would increase healthcare costs. Okay. So the Patient Protection and Affordable Care Act, it identifies care coordination as key in shifting towards value-based care models. Okay. So prior to the Patient Protection and Affordable Care Act, it was fee for service. Okay, you go in, you want a lab drawn, you want a CBC drawn. Okay, that you can get it done. This is what it costs. You need a Foley catheter put it in. This is what it costs. We can put it in for you. So what this has done, these acts have done, it shifted towards value. It added more value. The Affordable Care Act care coordination as fundamental in helping the healthcare to improve quality while reducing costs. So put more focus on the quality of care that we're providing. So I need you all to, in the chat, we'll do this one. We got several questions here coming up, but this one right here in the chat, just put, you all have been rotating through rotations. You're right here at the end. So you've been to some clinicals, and hopefully you have seen, or even you may have seen the nurses change shifts. Even in some of you all work in healthcare facilities, you've seen the nurses change shifts. And once you go to clinical, you change shifts. You come and you leave. So in the chat, at least just drop one sentence about what happened at the beginning or the end of that shift. So tell me, put a timer on here. What happened at the beginning or the end of that shift? Where am I go timer at? What happens at the beginning or the end of the shift? The, keep the messages coming. Just send it out so everyone can see it. So far, Carter, good. Miss Ford, Miss B, good. So what happens at the beginning or end of that shift? Good. Mid count, good. Reports on new admits and discharges, nurses report, changes with the patient. Great. Thank you all for those responses. Yeah. And you all were spot on here. A handoff report to the whatever nurse, home health, to the if we're in the hospital, we're in the emergency room, we're on med surge, we are at the urgent care. You know, we change shifts, we give report. There's a conversation that's had about what's going on, whether or not it is just a general run of things for that day. If you're in that urgent care, you know, general run of things that has happened, the number of cases that you come in that came in, and then even in that setting, and in the ER, you kind of if they do like a what do they call that? What we call it? Well, we just kind of say, well, hey, we seen this number of cases today. Several people came in with this or that. But nevertheless, there's a communication. There's a handoff. You know, the person that's going home hands off to the person that's coming on. And it includes everything, all that information, what the patient needs. If we talk about the medications, you know, if they had some events during the shift, you know, they had a little nausea, complained of pain, all of that information, the intake and output. Now, for the most part, what facilities do that uses a Cardex as we are documenting the facilities have a pre-programmed. So at the end of the shift, we hit a button and that Cardex print out and it prints out most of that information that we are handing off to the next person. So it highlights those things. Like, for example, if they, you know, what the intake and output was, you know, the diagnosis, whether or not they're a full code and all of that. But nevertheless, there's some communication going on. Okay. So what happens when a patient is set to be discharged? So come off mute. Let's hear from three people. What happens when someone is being discharged?
Basically, they do discharge instructions explaining like what's expected of them, whether it's like rehab, doing any exercises, the list, medication list, anything that they need to know that they're not going to have help with from the nurses in the hospital, basically.
Okay.
And patient teaching.
Got it. Patient teaching. What else? Someone else. What happened?
Follow-up instruction.
Follow-up instructions. Okay. Okay, good. And so when that client is leaving us, like you're saying, we're sending them on there, we're putting them on the boat, and they're going sailing off into the sunset, whether or not it's home, whether or not it's to another facility. For example, they might be leaving the hospital and going to a long-term care facility. They might be leaving the hospital and going back to assisted living, and leaving the hospital and going home. Long-term care for rehab and going home. Nevertheless, there's going to be some instruction, some communication. So we want to make sure that that information is clear. We want to identify our patients' learning styles. You know, once we establish those therapeutic relationships with our patients, they can tell you what they'll let you know, hey, I don't understand all that information on that paper. I can't read the information that's on the paper. So we want to make sure that we're providing clear information, instructions for them. Because think about it, if the information is clear and they understand it, even if we have to go ahead and make those follow-up appointments for them, like, hey, let's go ahead and get you on the schedule, even if you have to call and cancel the appointment. Let's go ahead and put the doctor's number, office number in your phone. Therefore, when you're supposed to call or when you have to call, you have that number already saved in your phone. That lessens the chance of that client not following through with those discharge instructions. But nevertheless, providing clear information, instructions. This right here will ensure that our patients more than likely will have positive outcomes, it'll lessen the chance of them having to come back to the hospital or come back to the doctor's office or the urgent care center to be treated for that same thing, because those instructions we've given them, they understood what their next steps are. Okay. All right. So what happens when a patient is set to be discharged to a long-term care facility with home health? We've already talked about that. Coordinating, again, when we talked about that care coordination, coordinating care across different healthcare settings and with providers is going to be important. The patient has to follow with the ortho. They have to follow up with urology. They also need physical therapy. Continuity of care, it involves that seamless transition. It's like sweet as what they say, apple pie, or I forget what that saying is. But nevertheless, it's a seamless transition. There's like no bumps in the road with this patient understanding and receiving the care that they're supposed to actually receive. So it ensures that patient information and treatment plans are effectively communicated and maintained throughout that care journey. So the client understands. They still might refuse some care, but at least they understand that they can make an informed decision about whether or not they actually want to follow with that doctor or not. So nevertheless, we have provided clear discharge instructions. We coordinated care with all of those on the healthcare team for that seamless transition. So effective continuity of care for the patient. So discuss what are some measurements. So now we said that. What are some measurements that will indicate that that continuity of care has been effective? And we kind of already said it, but so give us some examples of that. Continuity of care has been effective. Think about a patient situation, a scenario. What are some things? We'll give you a minute to think
If
about
they
it. Go ahead.
followed up like they were supposed to with the specialist or the PCP.
Mm-hmm. Yep, that's correct. What else? What are some tools or things that we can look at and say, hey, you know what, this right here, this patient, um, they did well. What's another example, you all? What else is I'm thinking about? Think about your care plans. Remember when we're implementing things, think about that. Our goal. What are some other measurements?
Showing improvement of goals that you have set that are measurable within the person.
Got it. Exactly. So the patient follows up. The patient is gaining and sustaining mobility. For example, you know how like physical therapy works with the patient, or occupational works with the person, and they're actually they complete all their sessions, but a lot of times they give them some activities or some exercises to continue. So a measurement would be that client, has regained their mobility, their full range of motion, and it sustained. Because we know if a person doesn't, if they do not use or exercise or either, do those range of motions, what happened to those extremities? What eventually happens? Contractions, right? So that would be a measurement. This client returned to their optimal level. They're out back walking again. They're driving the car. They're bathing themselves. But think about it. Depending on what type of surgery or um, chronic disease process someone has going on, initially they're needing total care. But prior to that surgery, they're more than likely did not need total care. So that would be a measure. Good, 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 good. So effective continuity of care, especially for older adults with multiple chronic conditions, can significantly reduce the risk of hospital readmissions. So we just said organizing that care coordination, just organizing that patient's care so they can follow up and do all these things. They've been starting on a new medication, making sure, and that new medication requires that we'll just say check their pulse before taking it. If it's not a certain number, the patient, doesn't take the medicine. So effective teaching, we taught the patient how to check their pulse, and or they may have a pulse oximeter that can actually check the pulse for them. But because they do understand, hey, if I don't see this number, or if I count, it is not this number, I don't take this medication, because if it does, it's going to more than likely lower my heart rate, for example. And what's going to happen? That client's going to have to go to the emergency room. So effective
Excuse
continuity of
me,
care.
Professor. Where I find these notes? I'm trying to follow.
This is just my review for next week. It's in your PowerPoints for next week. I'm just doing a brief overview. So this is week 4 and 5. And so that client understanding what that blood pressure measurement means, that client understanding what that glucose means, when they get it and they look, they have a sliding scale and it says, okay, I don't need to take any insulin if it's this number. If they understand that, then more than likely they're not going to inject themselves with insulin and lower their blood sugar, and ambulance is going to have to be called because they're hypoglycemic. Just trying to give you some examples of what these, when we talk about these concepts, I'm trying to just make it more lifelike for you so you can, because more than likely you're going to have next gen on your HESI and on your NCLEX. And so you're going to have to know more than the definition. We got to apply it to some situations. So those things I'm just making up. So by ensuring proper follow-up, you all said that. I think someone said medication management and coordination between care of providers. We've been talking about that. Patients are more likely to maintain their health and avoid complications that could lead to rehospitalizations. And so in the hospitals, I don't know if you all got a chance to rotate with the they call them different things, but it's like a QA, quality assurance nurse, where they actually look at, they look at it, look at the charts and say, hey, this doctor didn't follow the protocol, or it did, or this client, we've seen them several times. And this is, this is a position that you can also have in the long-term care facilities as well. It's usually just an additional task, or it's a shared task where you actually look at all the data. And rehospitalizations, falls, these are things, medication errors, these are things that they look at to see if the care is effective. Those are measurements that they actually look at, making it lifelike. So we talked about having to, we're in the middle, we're having to discuss and have all these conversations with all these people on the healthcare team about this, about each of our patients. It's going to require communication. So we're going to talk about communication here. Assertive communication involves expressing ideas and opinions openly while remaining respectful to others. Okay. So assertive communication is respectful, is direct, helping to ensure patient safety, and interprofessional collaboration is actually done. Okay, because going back to that situation I made up about the physical therapy and the doctor. So in the event that we know that the ortho can only see this patient, they only have this one appointment, they really want to get them in, and we know therapy is coming in on that day, and they usually see the client in the morning time. Okay, but that's what time the appointment is. So it's going to take not being rude, not being aggressive, just saying, just laying it all out. Hey, this is the only time that this doctor can see this patient. We have asked for alternative dates and times. This is when they can. And so we're coming to you. We want this client to receive all of the care that they need. So knowing this, that this is the only time an appointment, or they have an alternate appointment, but it's still in the morning. We know that you're here all day. Can you, is there a patient that you can swap out the times that you see? So that is not being aggressive, not being rude, disrespectful, but it's clear, direct communication. It is ensuring that this client is going to receive all the care that they're supposed to actually have. Responses that focus, and still talking about assertive communication. We're not bending the rules. We're not making up things that are not true. It is just respectful and direct. It is responses that focus on shared goal of quality care without placing blame. Okay, so we have notified everybody. We notified PT. Hey, this is what we need to happen. We tried to change the appointment for this patient, and PT says, hey, no, I'm not swapping. I can, but I don't want to. In the event that that client does not receive that physical therapy and they mark down whatever they mark, of course, we look at the notes and everything too. And so all of that information is brought to a team, and a discussion is had about what we're not placing the blame on physical therapy, but we just want to, let everybody know that, hey, We tried to coordinate these appointments. We know the usual, but this one day, we need this client to go see this follow-up doctor. So, but this helps create a safe environment for communication. There's no miscommunication here. So positive outcomes include improved teamwork. And so going forward, if we're being open about all of this and being proactive rather than reactive, the next conversation with the therapist or and when you call that doctor's office, because you all gonna get a chance to know each other. Like, hey, there's your patient. Do they have to seek therapy? Do they have anything else going on? Because we can change this appointment day and time. That's what those conversations will start to sound like. And then on the other hand, therapy's like, okay, hey, I know this patient just had surgery, and I know they're supposed to follow up. Can you go ahead and let me know when their appointments are so I can move things around on my schedule that day? So that's how that teamwork goes, and those conversations will actually
Excuse me, Miss Ford.
mm-hmm.
Are we standing here the whole time?
Yes, you have that choice, but yes, we have to meet, honey. Your board of nurses said we have to have this seat time. Yes, ma'am. And so, we haven't taken our break, so we can push that toward the end. But that's what your board of nurses say. Yeah, this is not like those classes that only.
Okay, no, that's what I was asking. Where you were gonna give us that break to the end?
Oh, I'm gonna give you your break, Miss Bill. We
Okay.
we don't miss that. We don't miss
All
that,
right.
but yeah, we're gonna push. But in the meantime, if you need to step away, just put a message in the chat.
Okay.
Yes. And so so that's how those conversations will go going forward, especially because you'll get a chance to, you'll know the doctors, they'll know you, the staff that they have, and as well, you might be on the staff at the doctor's office. And so when you're talking to that home health nurse and you're talking to that therapist, those are conversations and things that you all will actually discuss. But hey, just being proactive. Is this client? Do they have anything else that we need to be aware of? Because on the doctor's office side, they don't want to miss appointments. They want to make sure that everyone that they schedule, they have someone in those slots and they actually see them that day. So if you're in that doctor's office, they're gonna want you to be communicating with the patients and saying, hey, we have you down for today. They send out the text messages, they make the phone calls, we have you down. We just want to confirm that you're coming. And in the event that you can't come, let us know so we can put someone in that slot. And so that is part of still assertive communication. We're letting them know, hey, we want to see you and provide this care for you, but in the event, because we know things come up. And so, let us know so we can get you rescheduled. If you already know it's going to be an issue, let's go ahead and get you rescheduled. So assertive communication often involves using I statements to express one's thoughts rather than saying you this and you that. So using those I statements, because remember we said assertive communication is being respectful, honest. We're not breaking rules or anything like that. We're not trying to hurt people's feelings, but just being respectful and open about clear and direct about our communication. This approach allows honest expression without blaming or attacking others. It promotes effective interpersonal communication. We're still talking about being assertive. Okay, so I've given you some scenarios. So now the next thing is I need you to, in the chat, describe the nurse's verbal and nonverbal action cues for someone that is using assertive communication. So just think about, we're communicating. What are some verbal actions or cues that we may observe? And what are some nonverbal actions or cues that we may observe for someone that is using assertive communication? So let me put my little timer, I'll give you a minute and then share out in the chat so everyone can see. So what are some verbal and nonverbal actions or cues that we might observe if someone is using assertive communication? So share it out so everyone can see it. Let me see what your responses are. So what are those things that you observe? So body language. So tell me specifically what with that body language be like, or what would we see? So that's good, Miss Virginia. But specifically, if someone is using assertive body language, what would that look like? So everyone should be responding in the chat. So what are we observing if someone is displaying assertive, not aggressive, but assertive? What are those things we would see? Okay. What would those facial expressions look like? Assertive. Good. Good posture. Okay. Got it. Got it. Got it. Good, good, good. All right. Uh-oh, it's not changing. Okay. Again, let's go back and talk about assertive communication. So those were some good examples that you placed in the chat. Assertive communication involves conveying confidence through both verbal and nonverbal cues. Let's see, how did you all do? Maintaining eye contact, speaking clearly, and adopting confident posture. Ooh, you all were spot on. And all positive aspects are all positive aspects of assertive communication. Assertiveness is indeed a method of self-expression that respects both the speaker and the listener. It involves communicating thoughts, feelings, and needs clearly and directly without being aggressive or insulting others. Assertiveness then is a way of expressing oneself without insulting others. That's a repeat. It further emphasizes and communicates respect for the other person, although not necessarily for the other person's behavior. So is that person, we can't control the other person. So, but it's just for our behavior, ensuring that we are being assertive, not aggressive. Okay. All right. So then in the chat, let's look at this one. Describe the nurse's verbal and nonverbal action or cues for aggressive communication. So we just talked about assertive. So what will we be observing if the nurse or the physical therapist, dietitian, they are exhibiting aggressive communication? So share out to everyone. Pointing a finger. Got it. Fist clenching. Got it. Shouting that closed off. Yes, you all got it. Got it. Got it. Got it. Good. Uh-oh, the slide's not changing. Okay, so we said insulting, rude, and then even being unresponsive. Someone is the patient is communicating to you, and you're just ignoring, just being unresponsive to them. That is a form of being aggressive. Because they're asking a question. Why aren't we giving a response? Got it. Okay, so the most important part of communication, particularly therapeutic communication, is going to be this active listening. We have all these different ways that we active listen here. We're going to talk about that in just a few moments. Therapeutic communication is an interaction between the nurse and the client, focusing on what that client needs. Think about that whole client. What are their preferences? What do they value? What do they understand about their health care? What goals have they set? Okay. Okay. So this active listening, what is the purpose? Discipline, attention, focus. The only sense that we don't use is the sense of taste. So what are we seeing? What are we hearing? Okay. Just so that things are not misunderstood. We want to listen to the words, hear what they really are saying. So effective collaboration involves sharing observations and inviting input from other disciplines to optimize those client outcomes. So going back to the physical therapist, the physical therapist says, hey, the patient in 201, I go in and they're refusing therapy. It's the second day I went in. So they're coming to you as a nurse, sharing this information. And so, that's a discussion that we need to have. Like, what are they, is the patient just outright saying no, or are they stating other things? If so, what are they telling you? Well, the patient just say, hey, I'm not awake yet. So if they're saying it's the time of day, well, can we not change it? Can we put it a little bit later? It might not be, because some of those therapists, they do come in like for that 2 hour block. Well, can this patient be the last one that you see for that day? Just so that, we can ensure that this client gets all the care that they actually need. So this right here are these active listening techniques that more than likely you will be using, or you've already used when you were doing your assessment, as you were going back in reassessing your clients at a minimum of every 2 hours. You go in, you might ask them to, you might clarify a question. You ask the question in response to the patient, something that they have actually said or stated, just to ensure that you understood correctly. Because sometimes there's a miscommunication with the information that the sender sent to the person that was receiving the information. Sometimes we will have to use sounds or words that encourage the person to keep going, and keep, okay, yes, okay, keep going. We may even do those hand motions. In active listening, we have a patient that is this remaining silent part is different from that unresponsive when the client was asking us a question and we were not responding to them. With this part right here, active listening, the client, sometimes because you've established those therapeutic relationships, you will be the one that they will just share everything with. And they just want someone to just listen to them. They don't want any advice. They just want someone to be there to listen. And that is therapeutic, to just be there to listen, let them just vent, so to speak. So we talked about using those I messages. We said that was being assertive, not aggressive. We do want to make sure that we keep our promises. If like we're saying, hey, I'll be back to bring you your, a refresher water pitcher, or I'll bring your pain medication back here shortly, then it's 5 hours have passed. It's the end of shift. Just making sure that we are doing that. We just talked about that body language of someone that is aggressive versus someone that is assertive. So just being aware of that. So then the negative communication, the one that kind of trips us up as the nurses, because we're just so used to people coming to us, our patients, they're like, well, nurse, what would you do? Giving that advice. We want to ensure that our clients, patients, residents, depending on what setting you're in, that they make the decision that they want. So how do we do that? We make sure that they have enough information so that they can make an informed decision. When they say, well, hey, nurse, what would you do? Just, put it back on them. Hey, do you have questions? And if you do, what are those questions that you have? So we can ensure that those questions get answered. A lot of times the patients, sometimes they will, the doctor will come in and they'll go on over this information, and sometimes they'll have them to sign off and they leave out. Wait till you get in there and say, I didn't understand anything that doctor or the dietitian or whoever was in here saying. So it's going to be on us to, get that information back to them, in identify their learning style and have a conversation again. That healthcare provider, I have to come back just because we want them to make that decision about their care. We don't want them just signing off on something just because, they thought that they had to. No, you need to make an informed decision about whatever care that you're going to receive. So we talked about that handoff report. And even if we're not handing off, we're having to call the healthcare provider because something has happened. We use this SBAR. It is a structured way of helping us to communicate everything that's going on with those clients. I don't know how that got mixed up on that slide, but anyways, I'll read it. The Institute of Medicine recommends training health professionals to use practices and tools that support effective communication. I thought I had it on a different slide. So the SBAR is one of those tools that we use so that we can effectively communicate. Especially think about if our patient goes bad, our clients become unstable, there's a change in mental status, or whatever it is, we get lab results, critical lab results. This SBAR, it supports us. It gives us this guidance And you probably by now you probably rememberize or you've done SBAR. Usually we do it in clinicals. We use it to do the handoff report and everything, and also we just run some scenarios. And so we use SBAR to put all our information together so that it's organized. So this slide looks at when we're calling the doctor. Remember, this SBAR is just an organized way of communicating. So what is this situation? Why are we calling this physician? Is it critical labs? Is it that this client had a change of status? Is it that a medication error occurred? What is it? The why. And also, they want to know who they're talking to. So we give them our name. They want to know what room the patient is in, their location, and then the why, the problem. Then they need some background because remember, the healthcare providers, they're not there with the clients like we are. So we have to refresh, give them some background information, admitting diagnosis, the date that they were admitted, their current status. We want to give them their most recent vital signs. Now we can, if something's going on with the blood pressure or any of those vital signs, we can also give them the previous. Sometimes they'll say, well, hey, what was their blood pressure or pulse before now? And we can go back and give that to establish that baseline. So you can show that comparison that this has worsened. So the assessment, what do you think is going on based on the data findings? Okay, so we've collaborated with the RN and everything. They want to know your opinion because you're there most of the time with those patients. And then recommendation, goals of care, what needs to be done. Hey, this client's status has changed. Status, we have the vital signs is this. We more than likely probably need to move this patient on to change their level of care. They might need to be transferred to ICU. This client has fallen. They have limited range of motion. They have visible deformity. This client, we need to transfer this patient out to the emergency room and so forth. Just all different kind of examples. But when we're changing shift, we don't have to give as much. It's pretty much the same information, just some variations. That handoff report, we still use the SBAR to guide what we're saying, what we're discussing. So conflict resolution. So you all may be called on. This is a lot of facilities. This is an additional task that you can have as working in a facility. And usually conflict resolution goes to the ethics committee. So the ethics committee that might be one of those committees that you want to work on. Most facilities have ethics committee, public relations, and things like that. Conflict resolution. Accept conflict is a natural part of life. That means that the conflict is correct or not, but it's just something that happens. So be aware of, our own attitudes and behaviors in whatever the situation is. We want to take the time to think critically before reacting. We want to listen and learn. Identify if there are any gaps in information, because a lot of times when people are telling you something, they might not have listed or stated all the information. So you might have to do some more focused questions when they are describing what the conflict actually is, because we do want to address whatever the conflict is. It could be miscommunication, misinformation, or what have you. We do want to ensure that we resolve the conflict. This is just what we use to ensure that we are gathering all the information and coordinating and identifying what the real issue is. It's just another tool that we use to communicate. So we're going to talk about the chain of command. Now, if your patient needs an immediate response, then we can bypass some of these people on the chain of command. They need to eat. If this client is unstable, if an immediate response, emergency response is needed, then we don't have to wait to call the doctor. We don't have to go through the supervisor, and that's the next supervisor and all of that. And your facilities will tell you that. Even now, when you call into the doctor's office and things, they say, hey, if this is an emergency, hang up and dial 911. Don't not try to make an appointment with us. So they're saying, if you need an immediate response, we need you to hang up and seek emergency care because you need an immediate response. All right, so this is where we're going. This is just a brief overview of where we're going. Because remember, we just have 2 weeks to review this information and then you're being tested on it. The next thing you know, it'll be HESI time. It'll be time for you to take your NCLEXs. And so you will, nevertheless, you'll be ready because you've heard this over and over again and you know it in your sleep, so to speak. All right, so we're gonna pause here and we will let you all take your breaks and we'll see you on next week. Grades will be posted on Friday after we do the exam analysis, you all. Take care. We'll see you soon. Thank you. Miss Spellman, are you there? Hello.